Hey guys, Anthony Carey here with Function First in San Diego, California, and I want to talk to you a little bit about corrective exercise and biomechanics and the relationship between biomechanical stress and pain, and specifically long-term chronic pain that's associated with many of our clients. There's a bit of debate now going on, and for good reason, that we can't take purely a biomechanical profile and expect that to be the only reason why people are experiencing pain. We certainly know, the research tells us, and some of the leading experts in the world tell us, that the longer the person is having pain, the greater or the less chance there is associated with tissue. So in other words, the 90 days associated with the chronic pain label given to people has to do with tissue healing. And the longer the person has pain, the less that has to do with what's going on in their tissue, and probably a little bit more that's going on neurologically and obviously into the brain and the perception of pain. That doesn't mean it's all in their head. But with our everyday clients that have some kinds of aches and pains, typically we're taking a biomechanical approach towards their bodies, and we're looking at movements, whether it's posture or doing a screen for a squat or an excursion or a reach or that kind of thing, and we're correlating that with pain. And quite frankly, I believe that there's still a distinct relationship with that, because there is going to be such a thing as tissue tolerance and how much stress, whether the joint tissue or the soft tissue, muscle or fascia, can tolerate as far as loads that are applied to it on an ongoing basis without a chance to recover. There's a simple analogy would be if I were to walk and I was constantly having my knee driving in and knee valgus, where normally I walk like this, and you said, Anthony, for the next 12 hours, I want you to let your knee do that every time. Well, I'm probably going to experience a little bit of stress into my knee, mechanical stress that's ultimately going to manifest itself as symptoms. And in that term, it is a short-term type of issue that can be influenced through our corrective exercise. But if we're thinking about the person in long-term pain, and ultimately we do want to help a person move, maybe we use the biomechanics as a framework that helps them move with more confidence, feeling safer, and ultimately adding some variability to their motor system that constantly has them challenged and learning differently. Because typically our training variables deal more with looking at quantitative things. We're looking at increasing reps or sets or intensity or tempo or load or whatever that is. They're very often our variables. But when we start to look qualitatively, both at sequencing exercises, the interrelationship between exercises within a given program, and also the variability that we can introduce to our client's motor system versus just trying to add more to what we're already doing. And that inherent variability challenges their system on a regular basis. So there's actually a term called kinesiophobia that's associated with people that have a lot of long-term pain. And you'll see that even in your clients that may not think that they have long-term pain, but they're afraid to bend or twist this way, or they don't want to put all their weight on this knee. That's basically a fear. If we can convince their bodies by coming at it a safe, effective way that just happens to be very much in line with improved biomechanics, we might be doing them a very good service by helping them gain confidence in their body, and not necessarily by just reproducing or asking them to work through that pain and exposing them to more of the same thing, but actually coming at it from a different angle that challenges their motor system, helps the system kinematically come up with some different options that are a little bit novel, and the brain does not associate with fear or dysfunction. And we can do that with corrective exercise, because that helps us chunk down the movements and give people the opportunity to experience something novel, something different through their motor system. And that can be through many different avenues that we've all used in the past. You might be more comfortable with one type of technique than the other. But the most important thing is, are we in a controlled environment introducing variability with some kind of objectives in mind that we're working towards to help this person move better? And if we have not been able to improve what they're doing by doing more of the same, or trying to just take that same movement and break it down into smaller steps, then we need that variability. And I think that you're going to find that the biomechanical analysis and the value of that in the big picture of things is still there. But when we start looking at our clients with pain, and particularly chronic pain, we have to realize their system needs a little bit of different stimulation that helps them disassociate historically what they've tagged in their brain as painful to something that is safe and new. And therefore, they're going to be more confident in their movements, and you're going to be doing them a genuine service of helping them move better and improve the quality of their life. Thanks from San Diego. I'm Anthony Carey with Function First.